Go.
Tam's nervous because we don't usually record the intro live with guests. We usually do it before or after, but I've decided we need to do something fun and that we need to record live. Our intro, we can always edit. I always edit things if we sound silly. And this year we've started to put things on YouTube because we're trying to be like millennial, Gen Alpha, Gen Z. I don't even know where I stand. I think I'm a Gen X, so I'm learning how to type. Um, so, are you okay with video?
Yeah, of course.
Yeah, okay. I thought so after last night. Okay, so we'll do the intro and then we'll introduce you and then we'll take it away and you'll just get to take the stand. And then anytime we mess up, I'll just edit it out. But I can't wait to talk to you because there's just so much that we want to talk about, which we won't all fit it into an hour anyway. But welcome to the Pelvic Health Podcast. I'm Laurie Forner, pelvic health physio, PhD, and currently studying obstetric and gynecological sonography.
I'm Tam, pelvic health physio, educator, and total anatomy nerd.
And I'm Do, also pelvic health physio, and I'm currently studying medicine with the view to become an obstetrician and gynecologist, hopefully one day. We are three clinicians who love diving into big conversations about pelvic health with leading researchers, academics, and of course, frontline clinicians from all around the world.
So if you're a physio, doctor, midwife, nurse, or educator, and pelvic health is your jam, you're in the right place. So thanks for tuning in and let's get into it. Before we begin, of course, we'd like to acknowledge the traditional custodians of the land we're recording on today. We pay our respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples listening.
So I want to get very quickly into today because we are joined by Alison. Now, I talked to Matthew Linardi about your last name, and we both agreed that it's French and it should be Deslandes. But I listened to a recent podcast with you, and it's not. So before I do the full intro, Ali, please tell me how to say your name.
Oh, look, we are just some bogan Aussies, not these,
Deslandes.
fancy Canadians. So we are Deslandes. Yeah.
Deslandes.
Deslandes. Yeah.
Deslandes. Okay. Because my whole time I've been preparing this and practicing, I'm like, Ali Deslandes. I'm like, it's so pretty. Deslandes is
like
still pretty.
In French. I once had somebody overseas tell me I didn't know how to say my name right. And often when I last went to France, people just started speaking French to me and were gobsmacked when they discovered I could not speak French. So there you go.
Deslandes. So Ali Deslandes, a highly respected clinical sonographer and researcher with deep expertise in obstetrics gynecology and the diagnosis of endometriosis. She is a PhD candidate at the University of Adelaide, where her research is part of the Image Endo project. She's exploring the use of artificial intelligence as a learning tool to help sonographers transform transvaginal ultrasound, or if you're in Australia, transvaginal ultrasound. Now, this, I will totally admit, is ChatGPT, so please tell me if any of this is incorrect. Let's see how smart ChatGPT is. So far, have they done well?
Yeah, I think so.
Okay. The rest here, we've got Alison has authored and co-authored over 40 publications with a strong focus on endometriosis diagnosis, and she's presented her work at major international conferences, including the World Congress of Endometriosis, ISHUOG, many others. There's one, next weekend in Sydney, is that right?
Yeah, World Congress Endometriosis again.
Yeah, Tam will be there. She is
I'll
passionate.
Be there too.
And Joe too. Oh man, and I won't be there. Anyway, well, all of these women, but also Alison, is passionate about empowering other sonographers to build confidence in scanning for endo, ultimately helping reduce diagnostic delays and improve patient outcomes. She's the former president of ASM. She'll tell you what that means because I mess it up all the time. Has served on the board for 5 years, was awarded a fellowship of the Australasian Sonographers Association in 2022. And we are very excited to have you on the podcast. Welcome.
Thank
Ali.
you. I'm very excited.
Welcome.
Yeah, I do a lot of listening to podcasts, not being on podcasts. So I'm very excited to be on yours.
Yeah, well, we love your Instagram, so we know you are a good speaker. That is for sure. Amazing what you're doing with ultrasound, of course, in diagnosing endometriosis. I 100% wish that was around 25 years ago when I was going through it, because it would have made that process so much smoother and easier. And I know that many of us as pelvic health physios see a lot of patients with persistent pelvic pain, so lots of pain in their pelvis, not always sure why it's there and what's going on. Us as physios, of course, treat their muscles and their nerves and their brains and their nervous systems and can help. But more often than not, we'd love to know whether there is anything more going on. So things like, of course, endometrial cells being found outside the uterus, like endometriosis. And if that is possible via ultrasound instead of laparoscope, of course, that is brilliant, because it really does change, not in all cases, but in lots of cases, their management. So really long-winded kind of intro to the question, but the question is, can I ask where or when did the use of ultrasound for diagnosing endometriosis and adenomyosis first begin, and what were the early days actually like?
Oh, yeah. So that's a good question. So the early days actually started well before I came around. So basically, the South Americans get the credit for being the first. I think it was teams in Brazil that really started to investigate, could we see endo on ultrasound and could it be a useful tool? Because we'd really just always accepted you couldn't see it on imaging. You had to go in and do surgery to see it. It was in about 2003, I think, the first publication sort of started coming up. So just over 20 years ago now. I was still at school back then. So it was definitely before my time. But it very much focused on a surgical planning tool for imaging because, I'm sure some of your listeners know when endo is really, really bad, you get disease which infiltrates all sorts of organ systems, and you get adhesions that basically just make the pelvis very hard to visualize. You lose the anatomy. So when they go in surgically, they actually can't see what's there because all they see is a mush of anatomy that's adheres together. And what they have to do is the surgeons have to then very carefully start dissecting all that anatomy and restoring the normal pelvic anatomy before they can even really get a sense of where the disease actually is, and then resect the disease. So it's a huge process. It needs very complex advanced surgical skills. It needs a huge amount of time. It needs proper patient prep. If it's infiltrated to the bowel, the urinary tract, it needs those specialists, the colorectal surgeons or urologists, to come in and also assist in those surgeries. So what would often happen is these severe cases would end up with people closed up again, and they'd go for a repeat surgery. And so there was a real desire to prevent some of that happening, because that's obviously not ideal for anybody. So that was really the early days of imaging. Now, in Australia, we're pretty lucky because I've been very fortunate to travel the world and do lots of teaching elsewhere. And we're actually pretty good as far as we go with imaging. And I know some of your probably, endo suffering listeners will maybe disagree with that, but really on a global scale, we're actually doing really well. And it was really in about, I want to say it's about 2008, 2009, clinics in Sydney and Melbourne started offering imaging diagnosis of endo. It was very limited to certain experts that were invested in this space. But then my journey in it all started in 2013 because I started working with Professor George Gondis in Sydney in his private practice. And I, just because we met by chance, and so he started teaching me about endo because he was doing a lot, and still does, a lot of the research around developing techniques. And it was really interesting. It's been super interesting, I've realized, working alongside an expert, because you see these people usually when you're a professional in the abstract, you go to conferences and they seem like these, messiahs that are not human beings. They are actually human beings. And they also start at nothing. So it was really interesting working alongside Professor Condis in those early days and kind of seeing him learning as well and developing things and seeing the mistakes that he had made. And really what we were doing back then was so limited and primitive compared to what we do now, I think. And so it's really interesting, I think, from my own journey, seeing and, allowing myself to kind of get into that expert phase as well, where you realize everybody actually starts as the beginner. And we all learn. And you know, it's lovely if you can have people that have made the mistakes before you to learn from as well. And so, you know, that's kind of how it all started. But now I think, you know, when you look at the last 5 years or so, globally, not just in Australia, I mean, just we're coming along in leaps and bounds. I mean, there's so much more evidence, there's so much more research. We're refining techniques. There's really good education out there now. And there's finally awareness as well. So awareness from you know, patients to sort of want to demand non-invasive diagnosis, which is really driving things. Awareness from funding bodies. So we've recently had sort of Medicare announcements and things in Australia to, you know, actually say, no, we should be investing in these things properly. You know, funding into research, so it allows us to actually develop these techniques more. And then, you know, the profession's gone behind it as well. So you go to like ultrasound conferences and things now, and, you know, you see these lines out the door for, you know, endo sessions. It's amazing. Like people actually care about women's health. And so it's all those changes, I think, that have really led us to a point where I feel like we're on a precipice now where, you know, in another 5 years, we're going to look back on what we're doing today and be like, wow, we were so primitive back there. And I really think that the accessibility of endodiagnosis via imaging will be much, much better. I think we'll see a real reduction in a lot of the diagnostic delays. And overall, you know, while the diagnosis only is the first step in people's journey, I think that it will, you know, as you said, be a really important part to help to unlock what is the complexity of pelvic pain as well.
Very true.
Yeah. That was a great summary, essentially, of the evolution of, you know, where we've come from. So I suppose, can you just make it a little bit clearer for us? Where are we today? So what can you guys see? And when you're talking earlier about reporting, what things are you reporting? So we, I guess, as clinicians, kind of understand how good you are at the diagnosis piece. I note that you think in 5 years' time, of course, we'll be further down the line, but where are we now?
Yeah, that's a good question. So now in Australia now, every capital city, at least, you can find endometriosis imaging. It's generally still confined to the specialist practices. So it tends to be, you know, you go to a sort of specialist women's imaging type practice. That's where you're most likely going to get it. Still, a lot of the general radiology clinics aren't doing it for a number of reasons. But there is more and more people coming on board. We are very good, when you look at the evidence, at diagnosing deep endometriosis. So the bigger lesions which infiltrate under the peritoneal surface, we're very good at looking at those. And if you do a really methodical, systematic, thorough examination, we probably should be able to exclude deep endometriosis really as a cause of people's problems. I'm also very good at detecting ovarian disease, so in the form of endometriomas as well. So again, if we don't see any of those on imaging, we can be very confident a person doesn't have those. We're also quite good at seeing severe adhesions, so things like the pouch of Douglas obliteration and entities like that, which again make surgery, if that's the intervention that's planned, very, very challenging. Where we struggle a little bit is with the superficial or peritoneal deposits. They're super small, so I explain to patients that they often are like having little pimples on the surface of the organs inside. And just because of their size, we often are not going to see them. Having said that, there has been more and more work done refining those techniques where those of us that are doing a lot of endo imaging are now finding we're seeing superficial disease as well quite frequently. But a negative ultrasound certainly doesn't exclude it. So I think even the best imaging is really important for clinicians and patients alike to understand that. Unfortunately, we're still not at a point where a clear ultrasound means that there's no endo. But I think if the imaging has been done really well, we can be pretty confident that there is no deep disease and there is no ovarian disease, which is helpful in terms of planning therapy. If surgery is planned, you can be pretty confident the generalists are probably going to be able to manage that with those surgical skills. If there's deep disease or obliterated pouch, they need to go to the advanced surgeon straight away. But it doesn't always give that answer of the pelvic pain. I think the other thing with imaging, though, as well, is that, you know, pelvic pain, as I don't need to tell you guys, is very complex. And, you know, that we also exclude other things. So we exclude, you know, that they don't have ovarian cysts. We exclude that there's no fibroids. We exclude all these other pathologies, which it is often that process of elimination as well. So all of that is really, really valuable.
What
Yeah.
does often it comes up on the scan as like a non-moving ovary, like the ovary is not moving. Does that equate to definitely anything in the end? I have
No. So a few things. So there's actually, okay, so to backtrack a little bit, we have this document called the Idea Consensus Statement, which was published in 2016, which was a whole raft of world experts got together and put together a sort of proposal of how we should approach doing endoscanning. It's very comprehensive, and it kind of did revolutionize how we work because we finally all had a roadmap to follow. They included in that the assessment of what they call soft markers or sort of indirect signs, which is site-specific tenderness in the pelvis and ovarian immobility. And then there's direct features as well, which is seeing actual deposits of endo. Now, some of that early work on the soft markers, it was all around surgical planning, and could they somehow work out, you know, is there more likelihood of telling if people are going to have endo at surgery? My personal opinion, when you look at all the evidence, is that they probably were a little bit lacking in evidence to include ovarian immobility in the way they did in the Idea Consensus. Because if you look at it as a diagnostic tool only, so not surgical planning, a little bit of evidence that we do have around ovarian immobility is really poor as a diagnostic marker. So it's got really low positive predictive values. So when we see an ovary that doesn't move, we know from the literature it's actually more than likely that person doesn't have endometriosis. And so it might be that they have adhesions from something else, so a previous surgery or congenital adhesions, or it might just be that we had some technical difficulty moving the ovary, and that is really common with ultrasound. So sometimes it's really hard to just move an ovary. We, you know, might be limited by the position of the ovary. We might be limited by our scan technique. And if I'm going to get into your world, you would understand that when we, or Laurie particularly, now that you're doing lots of internal ultrasound as well, when you're pushing on an ovary, you're often pushing through the obturator internus, and when somebody's pelvic pain, that's really sore. And so sometimes we're really limited by their pain, our ability to move the ovary as well. And so I think in some people, this is again my opinion, purely just on what I've seen in clinic, but I think that we probably misdiagnose sort of ovarian immobility in some people that actually have pelvic floor dysfunction. And, you know, we then end up sending them down this route of go and see a gynecologist, consider getting a surgery, when really we should be sending them down the route of go and see a pelvic floor physio and try and get your pelvic pain sorted that way.
So is that
again,
because of the
it's really my
pain?
opinion. There's nothing in literature to support that,
But is that because of the pain when you press on the ovary, or because the ovary's not moving because you're not able to push because of the pain?
Well, that's it. Like, we don't know, do we? Like you know, you don't really know whether it's a technical thing. And I think those of us that do a lot more of it, and spend the time to kind of get in tune with the patient a little bit more, can sometimes get a bit of insight into that. So I often have conversations with patients about how, you know, just to validate as well. I mean, yeah, that was really sore when I was pushing on that. And, you know, and you start to explain kind of in my way that I don't really understand it well, but, you know, the mechanism of kind of a painful pelvic floor and how that could be a contributing factor, without sort of putting an idea into their head, which isn't right, because obviously pelvic pain in itself is so complex anyway. There's usually going to be more than one contributing factor in a lot of cases.
And knowing that people can be so sensitized, and knowing what I know, I'm finding it really hard to put pressure when I know they're uncomfortable and I know I need to do it. And I'm just like, yeah.
What do you say to them, Laurie, when you're doing it? Because if you know they're sensitized, because you can tell sometimes, do you just say, we really need to
I say
see? Or
sorry. I say sorry a lot.
I'm just
Like, I'm so sorry. Yeah, I'm like, I'm so sorry. And I even tell them, I'm like, I'm going to be apologizing a lot. I'm really just trying to see how things move. I'm trying to put a little bit of pressure. If it's too much and you can't handle it, let me know. But it probably will be uncomfortable. And
do you cue them down training of the pelvic floor while you're doing it? Like, just let go, let you sit. Yeah. Well, that makes sense, right? Let you sit, don't go, like,
I do a little pelvic floor education. Yes.
Yeah. Well,
when I'm there.
I feel like that makes total sense. And then you'll hopefully get a better image because you know, they're not guarding or
That's awesome to know, though, the ovaries, because it really does play on their brain. And then they definitely think they need an operation because they must have adhesions. Everything's stuck. Do you know what I mean? Which then, of course, makes the whole thing even more complex when that's not even a sign. That's definitely a thing.
Yeah, and I think, like it's all been an evolution. My opinion and how I teach things has been an evolution. And I published some work which was a little controversial last year, proposing something where we took ovarian mobility out. How you win friends. But really, I don't think we should take it out completely. I think it is a helpful marker and a helpful tool to have in our diagnostic toolbox. But I think we just have to be really careful with how we use that information and what we report back to patients with it, and understand why we're doing it. And I think sometimes in the ultrasound world, we get a bit swept up in sort of protocols that are standardized rather than thinking, well, why are we actually doing this? And what do we want to get out of it? And how does this benefit this person? And I think if they come in with a suspicion of endometriosis and we leave them with a marker that says they have a suspicion of endometriosis, but no direct features, we probably haven't really added anything. And if we give them a misdiagnosis or a false positive in some way, then I think we've just made their journey more complicated than it already is. And that probably hasn't helped people at all.
And I would
what
imagine
was the controversy? Sorry, keep going. But is this the paper about is this the paper you were just posting on social media about?
No. I do love controversy, don't I?
So do we.
This was a protocol that I published last year with Matthew Leonardi, actually, where we sort of proposed to simplify how we do endo scanning a little bit. And I think it was just, but people don't like change sometimes, and people don't like their ideas. So we got a bit of backlash for it. But yeah, like I think it's all an evolution, and I think it did make some people stop and think a little bit, which is always good. So, but that's probably a big discussion for another day.
And just following on from that, sorry, one last question and then I will stop hogging. I just get so interested because I have so many people going for these scans like all the time. I would imagine you both explain to the patient that just because nothing is found here does not mean, do you know what I mean? That they definitely don't have endometriosis, because I feel they walk away sometimes just being despondent because, well, I don't know what it is now. Thought it was going to be that. They found nothing. But of course, you can't see the little pimples all the time, right?
Yeah, absolutely. Yeah. So I often try and explain to my patients what the limitations of the test are. And that's an important part of the consent process, is that they understand what, they're actually getting in for. But yeah, we have this big thing, like on a societal level, so it's not isolated to endo or pelvic pain, where people really hang on imaging and the diagnosis. Like their scan is normal is such a big thing where they think that means they're normal. And I mean, I hate the term normal because it's like, but really, sometimes we chuck a line into reports for all sorts of things that will say something like no cause for the patient's symptoms identified, which is actually much more descriptive of what we do, because no scan out there or no assessment examination can assess absolutely everything that could be going on in the body. So, we're looking for specific things, and we can exclude certain things, but we can't necessarily exclude the rest. So in my clinic, one of the things we do is all our reports that go out have the final line says superficial endometriosis can't be excluded on ultrasound.
Love it.
So that at least hopefully is clear then to the clinician and the patient that, that still is going to be a consideration of their problem. But I think, like we have to be really careful with it, because people do really hang on a diagnosis. And I think, and while I certainly understand that, from the patient perspective, I think that, we've sort of created a bit of a monster, because if we accepted their pelvic pain earlier in their journey and we validated their experience of having a really negative experience with pain, and people didn't feel like they were sort of dismissed or their pain was minimized and things, I do wonder whether it would be different then when, we aren't able to give them all the answers. That would be so upsetting to people as well, because, I feel like they might be in a happier place where we're going to have to get a psychologist involved next time or something. But, I just feel like we always set people up that they need that diagnosis and validate their experience. But in actual fact, like, you know, if a woman just comes and says, look, I'm in pain and my life is not as good as it should be because of it, like we can actually just validate that with empathy and caring conversation, I think.
We believe you.
That's
It's
right.
helpful.
There's so much power in that.
Good one.
It sounds like you've already written a few papers, Alison, but I believe you've got one big project called Image Endo on the go.
Yeah.
Can you tell us a little bit about that?
Yeah. So Image Endo is the project that I work within. So it's run by the Adelaide Endometriosis Research Group. There is probably about 25 people, I want to say, involved in this project. It's massive. And it started a few years ago with Professor Louise Hull, who is the head of our group here. She's a gynecologist and fertility specialist and endo expert extraordinaire. Who did some Cochrane reviews looking at non-invasive diagnosis. And out of looking at everything, so this was back in 2016, it was really imaging that actually showed any promise. Like at that stage, there was, you know, blood tests really weren't showing any sign of being useful, that sort of thing. There's been some progress there, but imaging is still definitely leading the way. And so she sort of had this idea that, well, could we improve the diagnostic accuracy if we combine the power of a transvaginal ultrasound and an MRI scan with some AI, and, you know, AI can do everything. Could it, you know, help diagnosis? And so that's kind of how the project was born. And so if you fast forward to now, basically, once you go down, or you start on an endo diagnosis thing, whether you're a clinician, a researcher, a patient, it is a rabbit hole and you get sucked down it and you never come out. And so, this project that really started on can we develop an AI algorithm has actually led to what is now kind of 4 arms. So one is definitely around the AI algorithm development. So that's what we call Image Endo now. And I actually don't have that much to do with that arm of it. But that we've also then gone to what we call Triage Endo, because we love a good acronym. And that's around sort of primary care diagnosis as well, and how we work with GPs and how we empower GPs better, because they're often at the coalface of people that have pelvic pain and endo symptoms, how we empower them to access imaging, interpret imaging, and support them to diagnose and manage their patients in primary care. We also have what we call Endo IQ, which is what I mostly work on, which is around image quality in transvaginal ultrasound and teaching and training and expanding access to imaging. And that was kind of born because when you build an AI algorithm, you need an awful lot of data, and it has to be really good quality data. And one of the issues we have with ultrasound is that it's a very real-time examination. And so although we have kind of guidelines on how we do it, what actually happens in the real world is an operator does the scan and they spend 20 minutes, half an hour moving the camera around. And then we take probably 30 or 40 key images, really, where we do some measurements and things. So even though the scan might be done in the same way, what's actually recorded and can be used as sort of data for our algorithm development will be often quite different and not standardized. And so one of the problems we were having was, how do we get enough data to actually build our algorithms, which has still been an ongoing problem. But that sort of led to this kind of Endo IQ arm where we're like, well, could we just improve the data quality generally, and then we'll have more data. But really, at the same time, it's also, if we improve the data quality and we improve people's understanding of how to do scans well, everyone can just have scans without AI as well. So there's lots of benefits. So that's kind of what I work on. And then our 4th arm that we've got just about to start is Ad Image Endo. With the ad means adolescent. We just got a grant of about $2 million from the NHMRC to investigate endo diagnosis and care in people, in what we've termed young people. So we're going to actually go up to people aged 25. But yeah, we're doing 14 to 25-year-olds and looking at their experience. And hopefully what we're trying to do is we're trying to use imaging, see who we can diagnose with imaging, and then work out what their path, how their life is different after that imaging diagnosis. So we're going to follow them longitudinally and see, do we actually improve things if we can diagnose people really young? Or, you know, is there actually a tangible difference? Does it make a difference? Because some argue it probably doesn't, but we don't really know.
You know
Super
what we
cool.
haven't specified actually at all yet in this episode is when we're talking about ultrasound, we're talking about transvaginal ultrasound and not over the tummy, so in the vagina. And now you're talking about adolescence. We've talked about this before, and you've got some great social media stuff. How are you doing this in adolescence?
Yeah, look, this is actually still in protocol planning phase. So we use both transvaginal ultrasound and MRI. So some young people, some old people, some people are not comfortable with having something in their vagina, and that is fine. I don't think there is a set age. There is not like a point in your sexual life that you have to get to where you are like, yes, you're fine for transvaginal ultrasound now. You're fine for it when you're comfortable with it. So, that might be somebody that's 15. It might be somebody that's 50. It might be never. And that's absolutely okay. MRI is also not necessarily perfect for everyone. Some people get very claustrophobic in MRI machines. Some people can't have them because they've got implants and various things that are contraindicated. But it's another option. Generally, it's a bit more accepted for people with pain and things because you don't have to penetrate in any way. You lie in a very noisy machine for a while. But as long as you can lie still, you're okay. So there's those two options. Ideally, we'll use both and see what we can get because we want to learn a bit more about both utilities. But really, it will come down to kind of consent for those people and whether or not they're comfortable with it. I've got a bit of research that sort of informs some of this on adolescents at the moment, and I'm going to be presenting some of it in Mexico at the ISHWA conference, where we looked at sort of uptake of transvaginal ultrasound and the benefit of it in adolescents. And because in South Australia, where I am, we're pretty fortunate in that our consent rules say that at 16, you're basically considered an adult for a medical procedure. So at 16, if somebody wants to have a transvaginal ultrasound, we can just ask them, they can consent and it's fine. In other places, that might be 18, and then you have to go down the route of like Gillick competence, which becomes a bit more challenging. But so 16, we do quite a few transvaginal ultrasounds. I would say probably about 70% of those sort of 16 and 17-year-olds I see would undergo a transvaginal ultrasound. And I think we found in my study, I would have to look it up, but it was like 93% of the time it's fine. Like I think about 7% of people couldn't manage it, like due to pain or discomfort, and so the test had to be stopped. But generally, it was fairly well tolerated. And I think particularly in the group with pelvic pain, like they grow up very quickly, unfortunately. Like they're experiencing something that's pretty nasty, and even by the age of 16, I mean, if they've been having severe period pain and it's stopping their life, for 3 or 4 years, that gets to a point where you get sick of it and you really want an answer. And I think a lot of them are quite they're quite good at coping with pain because they're used to it already, and they're quite willing to try and find out what's going on. So interestingly, in that same study though, like we found that, I can't remember the numbers off the top of my head now, but I think it's like 15 or 16% of teenagers that we scanned as well we could see endo in. So it's not an insignificant number, and it's only probably slightly less than adults when you look at what has been published in adults as well. So it's a really exciting kind of space to be in, I think. And yeah, I find it fascinating, like, and a very different cohort to adults because you don't get that same validation piece, I think, with a lot of the teenagers because they haven't suffered for as long. And so some of them, I get a bit excited sometimes when I diagnose endo because I'm like, wow, look what we've done. Like we've changed your diagnostic process. I'm like, oh yeah, okay, well, yeah, right. You're like, whereas, the adults that are like 30, 40 years old and have been suffering for years, they burst into tears and like, oh my God, I finally know what's happening. So it'll be really interesting, I think, as well, to see that longitudinal data on what happens when we actually diagnose a young person and does it lead to better outcomes for them across the board. So we're going to be measuring a lot of different things. So it's a very exciting project, that one.
Very. Sorry, I'm hogging to one more question. I mean, it's truly exciting, Alison, like you said at the beginning, if we can shorten the diagnostic time, right? The time for diagnosis. It changes so many things for these adolescents, from chronic pain to their sexual experience, the whole work, which is great. I'm just wondering, so you speak of transvaginal ultrasound and MRI. in things like diagnosing breast cancer, there's like a triple assessment. And the third one being, so it's like the mammogram, ultrasound, and clinical exam. I just wonder with like, endo at the moment, I suppose there's acceptance of it being a clinical diagnosis, sort of the laparoscopic diagnosis. Can you see that maybe that something like that could happen in the future, that the diagnosis is like a triple? We've got the clinical assessment, the MRI, and the ultrasound.
Yeah, so I mean, it kind of is, but we just have not really had a very clear guidance and sort of pathway, and particularly in primary care, where a lot of that diagnosis really has to happen. It was only, I think, last week, RANZCOG released their new living guidelines on endo, and that's kind of clarified things a little bit more. Basically, diagnosis is really a bit of a journey because it's not a simple one, unfortunately, with endo. But you're right. I mean, it starts with that clinical assessment. So having a conversation with a doctor, so a GP ideally, about symptoms and sort of history and things, and then pelvic examinations as well, if somebody's comfortable with that, are really helpful. And then basically these guidelines sort of say that from that, if the symptoms are suggestive of it, we should kind of presume that there's endo until it's kind of, it's not. And they should start treatment straight away. And those guidelines actually now do give a little bit more than just going on the pill. Obviously, hormonal therapies are still really helpful and, quite quick and easy and cheap to kind of implement. But they also do suggest things like pelvic floor physiotherapy and other kind of allied health therapies to work within that sort of primary care space. Then imaging comes into it. That's probably like the next step because imaging, in theory, can be quite accessible. Like a GP can send somebody for a transvaginal ultrasound, and probably should if somebody presents with any sort of gynecological problem, even if it's purely to exclude other things. So, I mean, when I was talking about young people, I mean, the first step is really just to confirm that they have a normal uterus, like they haven't had some genital anomaly or something. And so imaging has that role. But ideally, if we can do these scans well, then we can get people that diagnosis and confirm that as well, which is really, really helpful, because then I think it allows us to make sure that we're sort of tailoring therapies which are going to be most beneficial, but also for the patient to understand that this is what's going on with them, and that's, then going to help them choose the right therapies for themselves as well. And then if imaging is negative, really what those RANZCOG guidelines and other guidelines around the world now suggest is that that's when we could look to surgery for a diagnostic confirmation if necessary. And I think in a lot of cases, therapy surgery rather certainly has a very big role to play, and a very beneficial role to play in treatment in terms of excising disease and removing lesions. So I think that there's, a lot of good merit for going to surgery from that point of view. And, if you can get that confirmation diagnosis if necessary, then that's also helpful. And, obviously they'll try and do histology wherever they can, but that's not always possible. I think, people forget that with surgery, I mean, they need to try and cut the lesions out. Sometimes they're tiny. I mean, they're not necessarily always going to survive that process to actually then go for histopathology as well. So, so just because the pathology, couldn't be done doesn't mean it wasn't endo. I mean, if the surgeon saw things that looked like endo, then it probably was. But it is quite that journey. And I think that you're right. I think the difference when you're dealing with endo versus something like breast cancer is that people will go, well, cancer will kill you, so we're going to keep doing these investigations till we can exclude that as the case. So we'll see people, I mean, I don't do any breast ultrasound now, but back in my day I did, and you'd see people that clearly have a benign lesion in their breast, and they'd still often have biopsies because you just wanted to be 100% certain it's not going to be a cancer, or also reassure them that if they come back in 5 years and unfortunately have developed cancer, it wasn't there then. With endo, it's not going to physically kill someone, the lesions. So yeah, there's not that same urgency, I suppose, in getting that confirmation or exclusion. But then I think what the patient wants is also very important, and what is going to help them on their kind of pathway of treatment, which is quite complex as well, is important. So what that diagnostic journey looks like for each individual, I think, is different, but it's it's certainly there. And I think, if people are happy with a conversation with a doctor and some therapy that helps control their pain and they need nothing more than that, then that is absolutely great, and that is all we need to make sure that they get. But if they absolutely need to get that histological confirmation, then I think we also should try and support people to do that when they can.
Love it. And there's some differences or new Medicare rebates, I believe, in Australia, which might mean, I don't know, something different for patients getting an endometriosis ultrasound. What's happened in that space recently?
Yeah, so it was budget night in March this year. The government announced there's going to be a rebate, a Medicare rebate specific to endo ultrasound. So if we backtrack a little bit, at the moment, if you go for a gynecological ultrasound of any type in Australia, there is one Medicare item number that can be billed for it. And that pays a rebate for most people of $93.70. Now, that is woefully inadequate for what is required to do a complex gynae ultrasound. They usually take at least about half an hour of a very highly trained sonographer's time. You need a doctor to report them. You need a very, whiz-bang ultrasound machine.
And how much is this scan usually?
So, I mean, it depends. But I did collect some data on what different clinics charge. So to do these endo scans, I mean, generally, the cheaper end of things was that people get charged about $350 around Australia, and then their rebate is $90. So they're basically out of pocket about $250 to have one of these scans. But some places charged a lot more than that, particularly in Sydney. Everything's more expensive in Sydney. So I mean, some people were looking at out of pocket costs of $400 sometimes for some of these scans. So really expensive. And what's more is I had a student do some research last year where we found that basically bulk billing services are non-existent for ultrasounds, because you actually couldn't do it. Like, you couldn't survive in a private business on $93 for these scans. It's impossible. So basically this rebate got announced that there will be a higher rebate now if we're scanning for severe endometriosis. We have no idea what that means at all. There will be a second billing code, because there is now a process that has to be followed. So the Department of Health is doing a review at the moment to work out what this should look like, how much it should pay, and who should be able to claim it. Because one of the problems is, if we as providers can all just say we're doing endo scans, suddenly everybody that's having a gynae scan will be having an endo scan because it pays more money, but they won't be done well, they won't be done properly, and so patients aren't going to be advantaged in any way. It just costs the health system more money because you're getting all these scans that are not right, and they're probably going to have to be repeated. So you want to make sure that the people that are able to provide the service and claim the rebate are the people that are actually properly trained and doing the scans properly, so that the patients can be sure that they're having the right test, and then their clinician can be confident that that's an accurate study where endo was actually assessed for. But the issue we have is that we actually don't have any sort of credential or training or certification that says this person has adequate training to diagnose endo. Because generally when you go for an ultrasound, a sonographer will do it, and we all do a graduate diploma level qualification. And so that does include gynecological ultrasound, but that's a very generalized thing. And our competency framework we work towards as sonographers basically says that an endo scan is an advanced skill. So that's not taught in that graduate diploma level. So you assume that a graduate sonographer probably doesn't have those skills. In reality, if they've trained in a place that they've been exposed to endo and had good mentors, they probably do have the skills. But most won't from that. Most have to do extra education. And all of that is very, I suppose, informal, in that it's often done through sort of self-directed learning and courses which are not necessarily recognised as any sort of, certification. Similarly, most ultrasounds are reported by a radiologist who, again, does a really comprehensive fellowship training to become a medical specialist. That's about 6 years of training they do. But again, they do just very generalised work in gynecology. There's no sort of, assurance that they really have a good understanding of endo. And then the other group that sometimes report ultrasounds in Australia are what we call the ONG sonologists. So they're the sort of obstetrician gynecologists that then do some specialised training in ultrasound. And there's a couple of pathways they can train through. One is the DDU through ASM, which is very comprehensive, but again covers sort of just general gynecology. And if they do a COGU course, which is the Certificate of Ultrasound and Obstetrics and Gynecology through the College of ONG, that does have a small logbook requirement that they have to have done a couple of endo scans. But it's actually still probably not enough that I would say you're going to be super competent. So we kind of have this dilemma where we don't quite know how they're actually going to manage it. But the department have said to us when we've had contact with them that there's going to be public consultation. So I certainly urge people that have an interest in this to try and get involved in that, because you tend to get one shot with Medicare. They work at a snail's pace to change things. So I think if we try and get this right, that'd be great. But I mean, I'm very happy that we have acknowledgement, like both for imaging professionals and for patients, that, you know, this is a complex area. It's time consuming, it's costly, like all of that actually needs to be taken into consideration and worked with. So I'm very happy that they're doing it. But yeah, what it will actually look like, we have to wait a bit longer to find out.
What is the best way to let the general public understand and know that difference between general and specialized for gynae scans? Because my friends, they're just like, oh, I'm just going to go to this place because I can get an MRI and a pelvic scan done at the same time. I think I might have endo. And I then have to have the conversation with them that actually they're not even going to look at the pouch of Douglas. They won't look at your bowel. You really need to go to a specialized place. But nobody knows that. Like, how do we increase that awareness of the general public, knowing that at this time, at this moment, you should probably go to a specialized place?
Yeah, it's really hard. And I think
TikTok?
well,
maybe.
generally, you know, all sorts of, you know, just public awareness things are very, very positive. And, you know, I think there's a lot of, even the clinics do a lot of, you know, really good education. I think as a patient, it's good to ask. Like, I think we forget that imaging is, you know, a specialization, and, you know, everyone that does imaging has done a lot of training to get to where they are at. Yeah. But, you know, like the training is generalized, like you're literally supposed to be able to image from the head to the toes and understand every organ system and every pathology system. And that's impossible. So you have subspecialists. And in the same way that, you know, most people that have a complex, you know, sort of gynecological problem would probably get referred to a gynecologist rather than be under the care of, you know, a general practitioner for the whole time, or, you know, a generalist surgeon or somebody if they needed to have surgery. You know, they would go see that specialist. And imaging, in my opinion, is kind of the same. Like if you need an expert opinion because something is complex, then you kind of have to find the specialists and go to them. But I always think it's worthwhile for people, the members of the public, to ask. So if you're booking in for your scans, like just ask, like, what are you going to do? Do you do an endometriosis scan? And if it, like, the answer is like, oh, like, yeah, I think so, maybe, like that actually means no. So you know, like, whereas at the special centers, they will be able to explain. Even the receptionist at my clinic can definitely explain. They're like, no, the technique is slightly different. These girls have all been really trained to look for endometriosis, and the outcome is quite different. And patients often see it once they come. Like, they kind of see, oh wow, you're really thorough. Like, I have a conversation with them, and they're like, wow, you really you know a lot that the last one didn't know. And I'm like, yeah,
but that's it. The last one didn't know. You don't want them to have that last one that they didn't know. I worked at a general place for a bit, and we had a 21-year-old come in with her mom. And because she wasn't sexually active, they wouldn't do a transvaginal scan. And they were both willing. And she was 21, and nobody asked her, like, oh, do you use penetration with anything else, like a dildo?
Yeah.
Like,
oh, exactly. Yeah.
And so that, but then they're the people that are going to have to wait another few years to suffer through it before they realize they've got to actually go to another specialized place to then actually get, you know, the proper imaging. And that's where I'm like, oh, I mean, yes, we're doing this podcast, but I mean, it's generally health professionals and not the general public. So we need these Gen Zs doing some dances.
And we'll get our like transvaginal probe, like, you know, dance. I don't know. I can't feel Gen Z, but
No. So I'm like, I can't do the WAP, whatever. Get my daughter. I'll get
Me
my
neither.
daughter to do it. She's
it.
14 and she
I
could,
mean,
she
Yeah,
could
good
totally.
idea.
the younger generation, they're very well informed actually compared to
Yeah.
question things, which is kind of a good thing because like you
Yeah.
listen to, friends and family and even like, a family member of mine had to go and have a CT scan, like for some issues. But knowing their medical history, I was like, well, actually, I know that they should modify the protocol based on your medical history and the things you've had done. And I said, well, where are you going? And they said it was one of these kind of dodgy, like little clinics. And the reason they said they were going there was they're like, oh, but the doctor sent me there. And I said, yeah, the doctor sent you there because they're literally like next door. And they bulk bill. And so I'm sure that your doctor has a lot of patients that struggle financially and things. I know this person does not and has enough money that they could have paid for a test. And I'm like, yeah, they kind of go there because of the convenience factor for their patients. But I said, actually, like you should go to this clinic down here. It's only 5 minutes further from your house, but they will actually review your medical history. They will modify the protocol based on what you need and you'll get a better quality scan. But, people don't know that and they just go, well, like my doctor would have sent me there. And it's like, yeah, but there's a lot of factors that the doctor has to take into account. And one is that, some people can't pay for imaging, unfortunately. And so, they have to go to like the bulk billing clinics when they're getting nothing. But, like when you're in a, 10 or 15 minute GP consult, it's probably beyond them to sit and go, now, Mrs. Smith, do you have enough money that you can pay for this scan if I send you here? And it's a complicated and, kind of uncomfortable conversation as well. So, but I do find a lot of the young people I see, they're much more informed and a lot of the, questioning, you see some of the local social media stuff around imaging. I mean, people will go in and they'll question, they'll be like, I've been sent to this place, but are they actually better? And people will talk about their own experiences, which is so helpful because, largely people will be like, yes, the difference is markedly different in terms of what this, specialist clinic does versus the average clinic.
Yeah.
Guys,
Look,
I'm really
I know, I was
sorry.
going to say we're running out of time. I know you
Yeah.
guys need to run and leave. We
go.
could talk forever. I'm going to put all these links so that everyone can find Ali and all the, articles and publications and webinars and the thousands of things that she has done. And we'll probably have her back. And thank you so much for your information today. And yeah, we'll see you back on here again at some point.
Thank you. It's been a pleasure.